Hi guys, so welcome to video 2 in this series. So we are busy with the 3-part dry eye training series. If you haven't watched the first video, please go and do that now. So the link is below this video as well. You want to watch the first one before you continue with the second one, because I'm taking you through this process in order for you to be able to implement this in your practice. All right, so in this video, we are going to look at all the nuts and bolts. What do you need diagnosis, treatment-wise, how to actually put this together in terms of clinical management in your practice. Right, this is going to be epic, so please make sure that you watch the whole video. And down below, there's some more resources. I've made some more templates and things available for you, so check that out. And always remember to subscribe and hit the bell so you don't miss out on the next video. Video 3 is going to be amazing. We are going to do a lot of practice implementation. You really don't want to miss out on that, because that's going to bring everything together so that you can walk out of this feeling like you are empowered to go and structure your own specialty clinic. Okay, so let's get into it. Remember, watch it to the end, subscribe to not miss out, and I'll see you guys on the next one. Hi guys, Mariki here, and I'm really excited to bring you the second installment in this 3-part training series. Now, going into this training series, I told you that the focus of this is to show you how I was able to increase my practice revenue by 20%. And what I also told you is that I continue to do that on a month-to-month basis. And the most important thing is I want you to walk away from this knowing how you can actually do this too. In this video, I want to show you, and I want to teach you how to become efficient with your dry eye patients. So there's a few steps that are quite important when it comes to efficiency. The first thing is you need to set up a standard protocol. With dry eye management, protocol is essential, and there are published protocols that really do work. So we don't need to reinvent the wheel. We just need to make this work in your system, in your practice, and you need to set these kind of procedures in place and run it from there. The second thing is you need to know how and why to do your dry eye diagnostic procedures. Like I said in the first video, knowledge is key. You cannot do this without having the adequate knowledge and without knowing what you are doing and why you are actually performing that procedure. So we are going to go through that as well. And then the third thing is that you need to get your practice team involved to streamline the process. Now, I know I said that we don't need to train the team straight away, which is still true. But there's certain places where they can really assist you in terms of getting more efficient. All right, so when you look at a standard dry eye protocol, we covered some of this in the first video, but I want to just set it in perspective, or bring it into perspective for you guys. So your protocol in terms of dry eye has 3 steps. Your first step is your screening process, where you will actually determine whether the patient has some form of dry eye problem. Your second step is your full diagnostic process, where you're going to do your full batch of tests to determine what type or what classification they fall into in terms of their dry eye. And then your third step is your treatment process, where your patient then, when they've been diagnosed, gets referred into a treatment plan that you have decided on based on your results from your diagnostic procedure. So your first step again is your screening test, which is done during your comprehensive exam. Your second step is your diagnostic process, where you actually do all of your diagnostic tests. And your third step is your treatment plan. Right, so when you're looking at your screening process, there's something that is very important that I want you to understand, and it's something that you are going to have to verbalize, probably to your patients as well as your team. The screening tests that are performed during the comprehensive exam is exactly just that. It's a screening. It is important that your patients understand that you cannot fully diagnose them or treat them based on their screening results. All the screening results say is that there can or possibly is a problem, and that they might need further testing to be able to determine what that problem is. Please do not get in the habit of telling patients that they have dry eye disease, because that might not be the case. All you've done is you have just established the fact that there is a problem. And the way that you speak to patients at this stage is going to very much kind of guide them into whether they are going to continue into this dry eye process of yours, or whether they are just going to walk out of the door with an eye drop. Now, you cannot also just stop at this process and then say that you manage dry eye disease, because you don't. You have to go through the full diagnostic steps and the classification and actually be adequately trained in terms of how to do those things before you can say that you're actually treating dry eye. The other thing worth mentioning at this point is that disease is a very serious term. I believe that dry eye disease is reserved for those patients who have severe systemic illness that results in severe dry eye problems. A low TBUT is not dry eye disease, so be careful about how you actually talk about this to your patients. I will be referring to dry eye disease throughout the training just because it's easier, but what we are actually dealing with 90% of the time is dry eye problems and not dry eye disease. And it's very, very important that you don't get into the habit of speaking about dry eye disease to a patient that's just got some bad oil in their tears, for that matter. Okay, so let's just get back into the dry eye screening now. So we said the patient was there for the comprehensive exam, and you are just going to conduct the screening, and I want to run through the test batch with you quickly so that you can actually know exactly how that will then work. So the first thing, like I said in video 1, is your questionnaires. There are a few different ones. On the screen here, you've got the DEQ5, the speed questionnaire, and then the OSDI questionnaire. In terms of research, the OSDI and the DEQ5 are the ones that are used. Go and look at them, go and research them, decide which one you prefer. I personally use the OSDI mostly. I find it the most user-friendly, and that's just kind of the one that I go with. Then you can also get these things on apps. It's quite nice to have a practice telephone where you've got the OSDI downloaded on your telephone or on your practice cell phone. You can actually give it to the patient when they arrive at the office to do electronically. The only challenge with electronic apps is that you cannot save them. So you'll have to still jot down the answers. This you can actually get your team or your reception staff involved with to help you. Then we talked about tear breakup time. You can do a normal fluorescein tear breakup time. And yes, there's been a lot of questions about non-invasive and invasive. And you know what, if you don't have any other way to do it, this is still a good way to go. Keep in mind what your norms are. There's different norms between non-invasive and invasive TBUTs, but go with this. It'll be part of your flow, part of your general consult, and it'll give you a good idea of what's happening on that ocular surface. Then after that, you do your staining patterns, both your fluorescein as well as lissamine staining patterns. Lissamine is one of the most underrated stains in terms of dry eye, and it gives you a good idea of what's happening on that surface, specifically between the lid and the globe. If there's friction there, you're going to see it with lissamine. So you really want to make a habit of doing a lissamine stain during your comprehensive exam to kind of see whether there is ocular surface disease or not. So that is basically your screening tools. This is a chart from the DUCE2 study, which just shows you exactly what that screening process looks like, and that you basically only need a positive questionnaire and then another positive on the other side, a non-invasive TBUT or a tear-BUT for that matter, as well as a stain, and then the patient is classified as a dry eye suspect. Now you'll see in this chart, osmolarity is still included there. I have left it out on purpose because most practices, specifically in South Africa, do not have access to an osmometer. From my work internationally, that is actually quite an international thing. Osmolarity is said to be very good in terms of dry eye diagnosis, but it is not something that is standard procedure or done standardly within most optometric practices. So we're going to leave that out for now. We're just going to go with the ones that I've just talked about, the questionnaire, the TBUT, and then the surface stain. Right, so you would have done this now in your comprehensive exam. the patient has 2 of those tests that are positive or that they failed or that are outside of norms, they are now classified as a dry eye suspect. Right. You are now going to book them into the dry eye workup, where you are going to do a full batch of diagnostic procedures to determine in which classification of dry eye they actually fall into. Now, the dry eye workup consists of 4 different steps. The first one is the lifestyle questionnaire. Now, this is something that we've already done during the screening process, so you don't necessarily have to do it again when you're going into the workup. Then the second one is your topography test, specifically dry eye related. The reason the topography comes first is because it's non-invasive. Then after that, your slit lamp procedures, and then lastly, a Schirmer test, should you wish to do that. Now on this chart, I just want to give you a little bit of perspective here, is that a dry eye workup just becomes one of your further management options, just like prescribing spectacles or prescribing contact lenses is a treatment option or a management option. Just like doing a dilated exam or an OCT or referring a patient is a management plan. Just the same way, the dry eye workup becomes part of your management plan. And it's important to start understanding this in your mind so that you can start positioning your practice and positioning the way you speak about your practice a little bit differently. We as optometrists are so stuck in the retail space that we kind of think that our job is to supply visual correction, which is not untrue, but it's not the full scope of what it is that we do. And it's our own fault the way that we have positioned ourselves. So when you actually speak to your patients, you need to change the way that you talk. We need to say certain things and definite things like, we decided to give you glasses today as your management plan. This is the management plan we have chosen for you. Or I would like you to have an OCT done. That is part of your management plan. So patients need to understand that it's so much more than just spectacles. So if you have a dry eye patient, this is the same type of angle that you will take with the patient, is that you have other problems other than the fact that you cannot see. So my suggestion is, as part of your management plan, to have a dry eye workup, which includes X, Y, and Z. So there's a lot of shifting of the way that we think, but also the way that we talk to our patient that needs to happen so that we can get away from this discussion of, oh, but does it fit into my medical aid? Because that's the next question that comes. And yes, you are going to get that question, and we will deal with that financial aspect in the next video. But it is our responsibility to start changing the way that our patients think about what it is that we do. You are not going to do that overnight. And please don't get despondent if you don't get the responses that you are necessarily looking for. We are trying to change a perspective that has been set for many, many years. But the moment you start dealing with your patient, the moment you start changing the way that you deal with your patients, slowly but surely they will start understanding the way that you function and the value that you're adding to their life by giving them so many more options in terms of their care. Because at the end of the day, it's not about glasses. It's about them as a whole and what they need as a whole, and whatever it is that you can do to actually make that happen for them. And the dry eye workup is part of that. The dry eye workup is part of a management plan to actually focus on sorting out their ocular surface problem. Okay. So just back to what the workup is about: the questionnaire, the topography, the slit lamp, and then the Schirmer test. So let's go through what each test or what each group actually includes. So this is a chart that I restructured based on the DUCE chart that we saw a little bit earlier. But what I did is I actually listed the tests that fall underneath each one of those categories. So you'll see the first thing is the symptomology there. And what is kind of noticeable is that those first screening tests are now included here. They are all in here, right? The reason for that is if you decide for whatever reason to have the patient back for the workup, quite a week or 2 or 3 weeks after your initial comprehensive exam, it might be worth it to repeat these tests, especially if there's been quite a time delay. And if it's immediately after, then obviously you don't have to repeat these, right? Then if you look under topography, you will see there are 4 tests there. You have your, obviously your non-invasive T-BUT, your tear meniscus height, your meibomian gland infrared scans, and your tear interferometry. These are all things or non-invasive tests that can be done with your topographer. And from all of those, the only thing that you can really do outside of your topographer is the tear meniscus height. And then the meibomian gland scans are a little bit of a challenge, but there are some ways of trying to see the glands without an infrared scan. So that is manageable. But the other ones you really do need a topographer for. Then in terms of your slit lamp, you have your lid assessment. Now your lid assessment includes everything from the presence of blepharitis and Demodex to telangiectasia, and then the presence of swelling, what the meibomian glands openings looks like. Is there any keratinization? Are they capped? Are they open? And then in terms of the meibum expression, what the quality of your meibum is. Is it pasty? Is it fluid? And then obviously how easy it actually expresses. Then the second thing there is your normal T-BUT and your staining patterns, which were part of your screening, and then your manual tear meniscus height. And this is what I meant with your first test, that this is the one thing that you can actually do straight at behind the slit lamp, which really gives you a great idea of what's happening with your aqueous fluid. And then the last thing there is your Schirmer test. Now, with the Schirmer test, I only do it under anesthetic. Doing a non-anesthetized Schirmer is not clinically very significant. You want to know what the baseline tear production is and whether the person has a lacrimal production problem due to inflammation. Now, studies have shown that the Schirmer test, because of the presence of tear meniscus height measurements, has become a little bit redundant. So you have the option of actually excluding this should you want to. I still kind of like doing it, but the repeatability is a little bit of a problem. So this is really up to you. You can decide to do it or not. Now, the other thing I want to show you, and if you look at these arrows here, so the orange arrows are showing you the tests that are done to specifically classify aqueous deficient dry eye. So tear meniscus height and Schirmer tests are the only 2 tests currently available that measures the quantity of aqueous fluid. This will be your determining factor whether the patient has an aqueous production problem. And this is where it's very important now to refer to the norms ebook that I gave you guys, where you can actually determine whether the amounts that you are getting is inside or outside the normatives. Then the second one is the blue arrows. These are the ones that are done for evaporative. So your meibomian gland infrared scan, your interferometry, and your lid assessment normally points to more of an evaporative problem. And with these patients, you are going to have an oil problem, and lids are the main culprit when it comes to evaporative disease. So this is the exact flow of what you would do during your dry eye workup. You have to do the symptomology, then you start at a point, start at your topography, work your way through each single test all the way down, and make sure that you do every single test on this list. Once you've done all of it, you can take all of your data, look at it, make an assessment, and then classify the person either evaporative or aqueous deficient. Keep in mind that you have many patients that's got some form of combination problem. And dry eye problems are more on a scale of between evaporative and aqueous deficient rather than one or the other. And I have personally found that women tend to be more likely to have a combination of the two, whereas men tend to be more on the evaporative side. This has probably got to do with the systemic medications that women tend to take, and also hormonal changes, which will affect the production of the actual aqueous fluid. Then once you are done with your complete workup, it is very important to get your patient involved. You want to go through every single test, explain to them what you found, and give them an idea of what you can and possibly cannot do about it. This portion takes a little bit of time, and this is something that is important for you as the medical professional to deal with. There are certain things that you can hand over to your team, and they can probably just recover some of the things that you have discussed. But I really suggest that you go through your photographs with your patient. They normally love seeing their pictures, and they understand things better when you actually show it to them. They also tend to be more adherent to what it is that you tell them in terms of management when they can actually see what it is that you have done. So don't think that your patient doesn't understand, because they're going to walk away from you and probably go and Google whatever it is that you told them. So give them as much information as possible. Have a pamphlet available that you can give to them so that they can go read it at home. Give them the information that you want them to have, rather than letting them go and finding their own information, because you want to be in control of what it is that your patient has in terms of management going forward. And that brings me to the next point, and that's templates. I've created some awesome templates in my practice in order to make my life easier. And some of you has already benefited from that. In the last week's group, the first couple of comments on the feed received my Dry Eye record card template. And a record card template is incredibly helpful because it saves you so much time in having to not write everything down. The same applies for a handout template about meibomian gland dysfunction, or about whatever treatment plan you are kind of facilitating with the patient. These templates save you time, it saves you effort, and it saves you from having to go through every single detail verbally with the patient. So then obviously it'll save you a lot of chair time as well. Now, I just want to remind you again that please, you do not have to understand everything that I've told you right away. I wanted to give you enough information that you could actually go away from this and set up your own dry eye practice. So if you're feeling a little bit overwhelmed, please don't stress. It's completely normal. This is just a bit of big picture stuff and trying to squeeze as much information into this video as I possibly can. There will be an opportunity for you to join me into the next stage of this process, where I will actually teach you this step by step, hold your hand, and get you going with all the templates and all the advantages so that you can get this going as quickly as possible. So guys, that brings us to the end of video 2 of this training series. In video 3, I'm going to show you everything about setting up shop. This is probably my favorite video in the series, and definitely the most questions that I've received is on this specific topic. This is the technical, in practice, implementation stuff. I also know a lot of you are stressed out about this step, but once I've showed you how it works, I think that it's really going to set your mind at ease, because I'm going to show you how to structure this in such a way that it's not going to take up much more of your time. It's going to generate the extra income we spoke about, and it's going to make your patients happy. And once again, if you have any questions or comments, I would really appreciate it if you would go over to the comment section below this video and leave me a message there.